Paul?
Yeah, thanks, Connie, and thanks, Marina, for getting us off to a great start. And in our courses over the years, we often try to make sure we add at least one talk that really digs into the underlying disease that we're dealing with. And I think Marina did a great job with that. I'm happy to introduce the next talk. I think those of you that have been to other large medical conferences often see a kind of best literature review kind of talk, what's happened in the past year, and we're going to try that. And it gives me a chance to mention that when Roger talks about the IAS, to tell the audience, remind the audience that organization it's a great organization, but it has nothing to do legally or any other way with IAS-USA, which is a completely separate one. But the IAS, as we know, the International AIDS Society puts on a major meeting every year, but especially every other year. And Roger is going to give us an update on that and on recent literature. So it's going to be a really interesting summary of kind of where we are. Roger, and it's not Roger, it's Roger, is from Francophone country, Cameroon, not currently still in the World Cup, but Roger trained there and then came to the U.S. and worked at Tulane University, a university with a long history of work in global health and did work in parasitology there. Finished his training at Wright State in Dayton, Ohio, and since then has worked in the South, both at the University of Alabama, Birmingham, where Mike Sagg, who will join us later, is a faculty member, and then more recently in Dallas at Southwestern, where he's very active and also serves as the section chief for infectious disease at the VA, the North Texas Healthcare System VA. He does a lot of clinical trial work and clinical work. And Roger is going to take us through an update. In case you missed it, updates from recent publications and meetings. So Roger, welcome to the program and take it away.
So I apologize for this. And this lecture titled, in case you missed it, a subtitle could be The Cure for the Fear of Missing Out, or the Cure for FOMO. It allows us to run through the presentations and publications that have come across in the past few weeks or months. And here are my disclosures. I have received research fundings from VIV and Merck and have served on the advisory boards of the following companies. Now, at the end of the presentation, what I would like the attendees to be able to do is to describe the clinical presentations of Mpox virus, outline new findings and complications of antiretroviral therapy, describe new data management and prevention of co-infections and superinfections, and then discuss key new findings on COVID-19, especially in the context of HIV. And here are the outlines. So we have the monkeypox, or Mpox as the rebranding calls for, overview, non-AIDS complications of HIV, HIV therapy, and we will no longer talk about the cure agenda. I think that we have a very comprehensive presentation of that earlier, and co-infections as well as COVID-19. For Mpox, what is new? And I think that it's great to start here with what I think is a success story, because what is new is that we have now gone through and probably largely past a monkeypox outbreak in the US and the Western world. Now, these publications from last spring showed us that the clinical features of monkeypox that we saw were rather different from what we had expected from the literature prior to this outbreak. And how different? We looked at one seminal paper in the New England Journal of Medicine of 528 cases from 16 countries across 5 continents. So basically, this is a very comprehensive overview. Fact number one, 40% of those who were in those cohorts were living with HIV. This is remarkably similar from other data that were put out by the CDC in the US. So almost half of people diagnosed with monkeypox or with mpox are living with HIV. Fact number two, the clinical presentation similar among those with and without HIV. However, there is also, I mean, the cases of complications occur. They're rare. They're probably more likely in those with immune suppression, including HIV. What was important also to note is that we have seen cases that are asymptomatic. This is an interesting analysis from a sexual health clinic in France, because what they did in that clinic, as per the protocol, was an annual swab to routinely look at sexually transmitted infections. In this particular analysis, those were negative for chlamydia and GC were tested for monkeypox, and they found 13 out of 200 were actually positive for mpox. And what happens then is that we had 2 of those 13 who later presented with symptoms consistent with mpox. So 2 things you can glean from this. One is that you may have people who are asymptomatic and possibly they can transmit the infection. Number 2 is that you could diagnose the disease in the pre-symptomatic phase, as was the case for 2 of these 13 patients here. So again, last fact about the mpox epidemic curve in the past year is that the presentation was slightly different from what we've seen in the literature. Number one, most people had very few symptoms, very few lesions. The rash was not very widespread. It was very localized, mostly in the genital tract. Fact 2, fever and other prodromal symptoms like chills and lymphadenopathy could occur before rash, as the name implies, prodrome, but it could also occur after rash or not at all. So not all people who develop rash will had prodromes of fever or other systemic symptoms. Then also has some respiratory symptoms that were detected in a number of people. In the management of people with HIV, you have 2 facts that one is that people with advanced HIV are not virologically suppressed with antiviral therapy may be at an increased risk for severe disease, as per the CDC Health Alert Network a couple of months ago. The second one being that post-exposure prophylaxis and antiviral treatments are available for those with mpox or exposed to mpox. Tecovirimat, which has been used significantly, has resulted in reduction in levels of some HIV medications, including NNRTI, but the clinical relevance of this is probably limited. Finally, vaccinations with Jynneos is considered safe for people with HIV. ACAM 2000 should not be given. It's a live virus. So that is what we've seen during the mpox epidemic. Now, apart from some preclinical data, laboratory data that had questioned whether the current vaccines were efficacious, the CDC analysis showed that unvaccinated people had 14 times the risk of mpox disease compared to those who were vaccinated. And that is a significant clinical effectiveness, probably owing to that, as well as owing to a significant behavioral change, because another CDC analysis found that the risk, the likelihood of multiple sexual partners found in dating apps or anonymous partners decreased by a half, which is significant. So a combination of all this, an efficacious vaccine, behavioral change, led to the fact that the number of infections peaked in the early August and now are very, very few, which is actually jeopardizing one of the seminal studies to look at the efficacy of tecovirimat because enrollment has now been significantly reduced. So now let's look at other sexually transmitted infections. We have probably not emphasized enough that in the previous analysis for Mpox, almost a 30% of people diagnosed with Mpox were diagnosed with a concomitant sexually transmitted infection. So it's extremely important to look for sexually transmitted infections when you diagnose Mpox. So now let's look at HIV and who is getting HIV in the US today as a moment of a clinical context. We have 41% Blacks and African Americans, 28% are Hispanics and Latinos. So it stands to reason that if you're going to stem the epidemic, you want to prevent it, or as the ending the HIV epidemic agenda requires, you have to focus on these populations. But we're not doing a good job of it. The PrEP to need ratio is the number of PrEP users divided by the number of people who are newly diagnosed in a given year. And that PrEP to need ratio serves as a measurement of how PrEP use compares to the need for PrEP in a population. And this has been compared by regions. You see here 4 different US regions: the Midwest, the Northeast, the West, and the South, showing you that the PrEP to need ratio has significantly increased, but mostly in the Northeast and mostly among white. Where is the new HIV infections? Mostly in the South and mostly among non-white. So the PrEP to need ratio gap increased over time in all regions. And so the racial gap continues to widen, and we need to address the epidemic where it's occurring the most. Now, another moment of context is the unmet need in sexually transmitted infections prevention. Now, this is the incidence of sexually transmitted infections in PrEP recipients. Now, you see here that in this particular analysis of 290 MSM initiating PrEP, 43% were screened per guidelines at PrEP initiation, and 25% had at least one STI. So this does 2 things. First, it tells us that it's really important to screen for STI prior to the initiation of PrEP and during PrEP. Why is that important? It's because we could now probably do something about those sexually transmitted infections. This is a study of men who had sex with men and transgender women with HIV on PrEP who had STIs in the past year. Now, randomized 2-to-1 to receive 200 milligrams of doxycycline within 72 hours of a condomless sex or no doxycycline with STI treatment at enrollment, and then quarterly and when symptomatic. So the quarterly STI incidence is provided in the table below by HIV status. You see that both among HIV uninfected who were on PrEP and among those living with HIV, the rates of the number of STIs were significant. So primary STI endpoints were significant in those in the control arm, about 30% in those on PrEP, and about 28% in those with HIV. However, those rates were significantly reduced by doxycycline post-exposure prophylaxis. In the tables on the right, you see that the risk reduction of sexual transmitted infection incidence per quarter was less than 40%, so reduced by more than 60% with doxycycline. And this held true with for gonorrhea and for chlamydia, even if the reduction of syphilis was not statistically significant. You see that the rate reduction was commensurate with that of the other infections, just because the syphilis infections were not enough in numbers to reach statistical significance. So another infection that we deal with regularly in people with HIV is hepatitis B. Co-infection with hepatitis B is a lot more common in Asia, East Asia, Southeast Asia, as well as in Africa. That's why this study was done in East Asia. And what it did is they looked at adults with HIV and hepatitis B co-infection who were treatment naive to both infections and had a significant viremia for both. For HIV, it was 500 or more copies per ml. For hepatitis D, was 2,000 international units per milliliters or more. And the HIV genotypic sensitivity was looked at for FTC and TFV, i.e. the active moiety of TDF and TAF. So what they did is they put some of these participants were randomized to receive bictegravir FTC TAF, and the other ones to dolutegravir plus FTC TDF. What we see in the figures on the right was the top one is not surprising because we had the two regimens were non-inferior in reduction of HIV viral load, and as 95% and 91% respectively had HIV RNA fewer than 50 copies per ml. But the figure on the bottom was the surprise because we now had statistically significant greater rates of reduction of HBV DNA in those who received bictegravir FTC TAF in blue compared to those who received dolutegravir plus FTC TDF in green. And so that is important. If I take you back to the table on the left at the bottom, you will see that there are two other endpoints that were different. One was a rate of ALT normalization in those who had abnormal ALT at baseline was 73% with bictegravir FTC TAF and 55% with dolutegravir plus FTC TDF. Now, if this data were confirmed by others, and I will say this type of data, you really want them to be confirmed by others, then it will be significant because you will have reasons for preferring FTC TAF to FTC TDF in those who are co-infected with HIV and hepatitis B. There was, however, for context, I'll tell you that when those two regimens, FTC TDF and FTC TAF, were tried in people who were HBV monoinfected, they had similar rates of virologic success. However, rates of ALT normalizations were higher in FTC TAF in those studies. And that could, again, this data had to be confirmed by others, but could mean that it's possible that TAF had a better penetration in the liver, as some studies have shown several years ago. Now, the low-hanging fruit, in my view, is suppressing viremia in people with HIV. We do that, as you see in the, even in the Alliance study I presented earlier, 95+% of people from the get-go. What has been completely difficult is decreasing the number of comorbidities that people living with HIV have. You can see here that that rate of comorbidities continue to increase over time, and we're talking about cardiovascular diseases, diabetes, chronic kidney disease, osteoporosis, and non-AIDS malignancies. More importantly is that the survival gap between people living with HIV and the general population is largely driven by these comorbidities. That gap has narrowed since the advent of highly active antiretroviral therapy in the mid-90s. It's in the gray line, but as is still just below 10 years. And that difference, that gap, is largely driven by comorbidities. So how can we address those comorbidities? We need to understand that there could be background risk in the people living with HIV because they had individual societal or behavioral factors that led them to higher risk of those. It could be the viruses. As Dr. Rassi presented earlier, even in people who are suppressed viremia, we do have a reservoir, and some of them are defective viruses, but we don't know whether those are still driving the inflammation and immune activation that people living with HIV have. But again, worrisome that treatments may contribute to those. So now let's look at the viruses. This is a systematic review of 12 studies looking at 5 cohorts and showed that 4 of these 5 cohort studies showed that spontaneously controlling virus did not decrease your risk of non-AIDS defining illness. So they have similar risk of non-AIDS defining illness as people living with HIV on ART, specifically cardiovascular disease and others. Now, cross-sectional imaging studies also show a higher prevalence of subclinical cardiovascular disease in these spontaneous controllers. So we need to continue to understand how to limit this. More interestingly is that in this analysis of the Casa Permanente and the partners, we see that from 2005 to 2009, the rates of new incident acute myocardial infarctions between people living with HIV and the general population were not significantly different. We thought we had a success story here. Not so between 2010 and 2017, where the gap appears to be widening. And it's very baffling to understand why that gap could be widening just now when we think that we have antiretrovirals that are more metabolically friendly, or so to speak. Now, it could be because the virus, like I said, itself is still inducing chronic immune activations. And if one virus is bad, 2 viruses are much worse, because cardiovascular disease in those who are co-infected with hepatitis C is greater. In this particular analysis, there was a greater increase in type 1 MI with age in co-infected people, outpacing the mono-infected people. So without HIV, adjusted hazard ratio per 10-year increase in age was 1.3, while with hepatitis C co-infection, that hazard ratio was 1.85, significantly higher. But now, we just had the IAS-USA guidelines this week released in Germany on, should I point out, on the World AIDS Day, December 1st, 2022, as you see in the bottom, on the top left. And in those recommendations, which I strongly encourage you to look at, INSTI-based regimens are recommended for most people with HIV. So it's normal that this class of drugs now is having significant scrutiny because we're really counting on it. Now, that's why the studies like the RESPOND created some trepidation. Now, what this study in an international collaboration of 17 cohorts showed that the composite endpoint of MI, stroke, and invasive cardiovascular procedure adjudicated events was greater in those initiated INSTI within the 6 months of initiation, and so INSTI exposure associated with 2.5-fold greater incidence of cardiovascular disease within the first 6 months of exposure compared to no exposure. Now, again, I should say data like this will have to be confirmed, but if you think you've seen this movie before, you'll have. About 13 or 14 years ago, with the DAD cohort showing that initiation of abacavir was associated with an increased risk of acute myocardial infarction within, again, months of initiation. Now, if these data hold true, that would probably suggest that whatever risk you had, maybe you already had built a plaque, initiation of some drugs might destabilize that plaque and cause you acute myocardial infarction. It doesn't mean that you build the plaque in 6 months. So we will see if this type of data will be confirmed. But we already also have some suggestions that other cardiometabolic complications might be greater with exposure to TAF and INSTIs, like here, what is now being termed metabolic associated fatty liver disease in this particular cohort. But again, for context, not all cohorts have seen the same. This is on the left, the advanced, the reprieve, sorry, which is a gift that will keep giving, and looking at reprieve, which is allows us to look at whether initiation of statins, pitavastatin in this instance, will reduce events in people living with HIV who would not have qualified for those statins by the ACS-CVD score. We look at here that obesity was greater, but metabolic syndrome was not greater among INSTI users. However, again, at the age 2022, we had an analysis that suggested a higher risk of AMI and congestive heart disease, but not metabolic syndrome in people initiating INSTI. So this is, of course, something that is continuing to evolve, and I hope we get some clarity on all that soon. Now, what we've seen here is this slide reminds me to say that while we've seen INSTI and TAF being associated with increased weight gain in many analyses, and that we also seeing some analysis suggesting increased risk of cardiometabolic complications. It doesn't necessarily mean that those cardiometabolic complications are a consequence of the weight increase from these drugs. It could be a completely different mechanism. Now we see here that change in BMI and outcomes in this EuroCEDAR study increase of 1 kilogram per meter square or more increases your risk of diabetes, but not of cardiovascular disease, while a decrease increase your risk of all-cause mortality. So weight loss increase all-cause mortality, and weight gain diabetes, but not cardiovascular disease. And this is published last week. Now, our management of treatment-experienced patients, not heavily, but first, second failure, is actually mostly driven by data we gleaned from resource-limited settings. And these are 4 trials that have actually informed us a lot. Before we had donning with all the drugs like darunavir, lopinavir, ritonavir, and atazanavir. But now we do have NADIA, which is a study looking at newer drugs like boosted darunavir and dolutegravir. What these studies suggest to us in this meta-analysis presented in Glasgow last month was that we did have a non-inferior outcomes in virologic suppression between the INSTIs and staying on boosted protease inhibitor in general. But the INSTIs were really superior in suppressing viremia for those who were viremic at baseline after the NNRTI experience. So these are data that, of course, we transported them to the US with some caveats, but it's important. Now, heavily treatment-experienced patients, maybe 1% of our patient population in a clinic like this data suggests, but they may be 50% of our headaches. And there are 2 buckets in a highly adherent but non-suppressive regimen, and those who are poorly adherent who have some tolerability or other challenges. And we know that if there were, since we're relying a lot on INSTIs, there is a caution now that we should exercise, because partial sensitivity to raltegravir at baseline, especially with prior exposure to raltegravir, which is why we should use it at BID. But addition of secondary mutation at T97A can result in rapid treatment failure in individuals with INSTI mutations. So this is what this group at the NIH has presented in the case report, just as a cautionary tale, emergence of T97A containing HIV from a large replicating population, and this is spread by recombination. So just a caution that number one, judicious use of these INSTI in people who INSTI experience, like have experienced all the INSTIs like raltegravir, and being aware of this. Because after this, options are limited. This is what we had, with the use of new drugs like ibalizumab for stemsavir, and like I said earlier, INSTIs like dolutegravir, BID, and the use of existing drugs that may have residual activities. So until now, but we may soon have yet another option, which is lenacapavir, presented in Glasgow last month, which showed in the week 52 efficacy here by number of fully active agents in the optimized background. You see that even with 0 fully active agents in optimized background, there was a 2/3 suppression to a viremia of less than 50 copies. Importantly, there was no relevant difference seen among subgroups who were considered most difficult to treat, like high viremia, low CD4 count, and others. So options will come. I will finish this with COVID. So in hospital mortality in people with HIV and COVID, number one is that those with HIV have a higher proportion of the comorbidities that we know are associated with COVID mortality. And number two is that those comorbidities actually increase COVID death in people with HIV. Put here, you see here chronic kidney disease and diabetes, as well as HIV parameters. So people with low viremia, high viremia, and low CD4 count. So, and then COVID again, what we've seen in the past month or two is alarming, because now we're used to seeing one variant or subvariant completely replacing another one, Delta and the Omicron, but now we're seeing is pretty much a swarm of subvariants. There is just a convergent mutation where you can see here, they all stumble upon the same mutations, and we have now many subvariants. I want you to focus now on BQ1 and BQ1.1, which are now respectively 30, each one is now about 30% of circulating variant, because those are significantly associated with escape from our preventive and therapeutic options. As you can see here, that increased, and then XBB is rising. It's probably 2 or 3% now, but will soon join BQ1 and BQ1.1 in showing strong resistance to current anti-SARS-CoV monoclonal antibody for prevention, Evusheld, and then for treatment. And this again came out this week by this group at the CDC. I like this study because it drives home the point that the efficacy of bivalent vaccines in preventing symptomatic SARS-CoV-2 infection, and it protects from the waning of protection of the monovalent vaccines. And it was equally effective in the table in the bottom right, regardless of the number of doses of the monovalent vaccine that you have gotten before that bivalent dosing. So important is one of our most needed modality now. So, and this one, just to reiterate the fact that BQ1, BQ1.1, and XBB are very resistant to all of monoclonal antibody options now. And while we still might be avail ourselves of the remdesivir, nirmatrelvir, and molnupiravir. And this is what led to just last week an announcement for the FDA that no longer authorize bebtelovimab for the treatment of COVID-19. This study in Japan that I will finish with in the next 2 minutes is very important, because that cohort has been used to showing us data, and this is live virus data that shows that while all these monoclonal antibodies that we have here, and I will show you that in this column, the one column is bebtelovimab. So there's really no efficacy of bebtelovimab against BQ1.1 and XBB. And then on the bottom, on the far right, is tixagevimab and kilgavimab in prevention, also completely ineffective. However, because these lineages, BQ1.1 and XBP, actually also do have mutations in the RNA-dependent RNA polymerase that remdesivir blocks, as well as the MPRO, the essential protease that nirmatrelvir blocks. It was important to test that these drugs will still work on them, and they do. So we probably will be relying more heavily on those drugs, and so bebtelovimab is no longer going to be used, and tixagevimab, kilgavimab will be used, but with caveats that it may not work. So I will now be open to questions. I apologize for the snafu in the beginning of the talk.
Oh, Roger, thank you very much. And yeah, you're forgiven for this snafu at the beginning of the talk. There are a number of questions. I had one to start with, just the observation that it's that the monoclonals for COVID are obviously difficult to produce, and it seems as though by the time we get them, they've lost a lot of their activity because the virus is still evolving so very rapidly, and a challenge, as you point out. But just a reminder to the audience that it's really important, I think, for all of us as providers to model safe behavior. And for sure, we should be getting our bivalent boosters, especially those of us that are over 60 or 65, and we should be talking about that with our patients. The rate of uptake is still far lower than it should be, considering that we still have this pandemic going on. It's absolutely not over. So that's a little editorial aside, but a number of questions, Roger. One is just tell us a little bit more about the Doxy Prep and why do you think it's working in gonorrhea, and tell us a little bit more about its effect on syphilis.
Yeah, so this is Doxy PEP, post-exposure prophylaxis. Probably Doxy PEP would work also, I don't know, but and so number one, there was a concern. The concern was the growing resistance in GC for doxycycline, and that could just be selecting for resistant strain. And this is a story that we need to continue to monitor, even as it was a small proportion of those who actually got GC in that Doxy PEP, sorry, I think had resistant strains. Now, why would it work? I think that it's likely that we will not need the full therapeutic dose that we use for established infections to prevent infection or abort. I guess this is probably aborting infections that are brewing after an encounter. So I would love to see a lot more data in that sphere to see.
Good. A question about renal dosing with the HIV-HBV co-infection with Biktarvy. Can you talk a little bit more about that, especially with the TAF dosing questions with renal failure or renal insufficiency?
Yeah, so I mean, I think that the 30 milligram of creatinine clearance threshold that is for TAF should apply with or without co-infection with hepatitis B. However, there's a small amount of data suggesting safety below that threshold. And again, this is something that should be important, whether or not you have hepatitis B co-infection. What I think is important in the Alliance data is also to look at the liver delivery of TAF. Actually, that led me to go back to the data, because we know that TAF has a higher intracellular level in the lymphocytes, but I was thinking this is the liver, has to be different. And indeed, in 2015, there was data showing that the tenofovir diphosphate, the active moiety, was higher within hepatocytes of dogs that were given TAF than given TDF. Now, that could be great, because that may explain this higher efficacy here. But that could also be something to watch for as to now getting to understand the rise in metabolic associated fatty liver disease and other things, but too early to tell.
So great. And a question, we've been hearing obviously about weight gain and INSTIs for a long time now, but talk a little bit more. The question is, do we understand that there's a relationship between INSTI weight gain and diabetes, steatosis, but not cardiovascular disease? Tell us about that. The audience found that surprising.
Yes, thank you. I think I should be, if you're frustrated in the audience, if you're frustrated about the lack of progress in understanding this weight gain issue, count me among you, because and what we have seen now for for 4+ years is that we have documented, especially in trials like Advance, that the weight gain with TAF and INSTI, especially when used in conjunction, was greater. Now, there has been some concern that maybe it's also because TDF, which has largely been replaced by TAF, was associated with weight loss, as well as NNRTI, it's like a 5 associated weight loss. That notwithstanding, we're living in an obesogenic epidemic, and it's affecting the same people or where the HIV epidemic is. And so that conjunction, so now we need to figure out if that weight gain is what is driving the nascent, the other cardiometabolic risk. I think that we don't know that. We have presented some studies looking at a higher rate of metabolic syndrome with INSTIs, others like Reprieve that did not show it. And also the increased risk of cardiovascular disease that we've initiated on INSTI in the European cohort by Nasgard et al. Occurs too early for it to be driven by the traditional risk factors. So we need to dissociate probably the two and dig in deeper.
So stay tuned. And I think your point about the fact that bad outcomes of decreased mortality or increased mortality really is now being driven by secondary consequences is really an important observation, and something that we should really be addressing. A quick question about MPOX. Starting MPOX, starting ARV therapy with a new diagnosis, low CD4 counts. Any thoughts about IRIS in that situation?
That's a good question that I don't know that there is enough data on that. The concerns that I personally have with IRIS is infections in the central nervous system. And otherwise, it's really something that we should not be very concerned about. Now, it's now known that, safe cryptococcal meningitis, we probably should be starting antiretroviral therapy as soon as we can in people who are diagnosed with HIV in the context of an ongoing opportunistic infection. And I don't think that MPOX should not be an exception.
Great. And there are a number of other questions. We're running low on time, but just quickly, a question about lenacapavir and tell us a little bit more about it. What drug class does it belong to, and any other thoughts?
Yeah, so capsid inhibitor, now this is a class that we haven't seen before, and it's likely to be something that can be used because of its very long half-life, and in very infrequent administrations. We're talking parenteral probably, and then so important that it's been studied in the study I presented, Capella, and in heavily treatment experience, also been studied in treatment and naive in a smaller study. So in both instances, been very promising. So what I imagine will come next is the optimal pairing. Now, based on the long half-life, the ideal pairing for dose parity will be long-acting antiretroviral. There is not a single study I know of now of new regimens that have more than 2 drugs. So, and so we probably are going to see that as well pretty soon.
Well, maybe at our next Chicago update next year, you can update us on that as well. Thank you very much for this. Really a nice summary of a lot of data. But it's now time to turn the program back to my co-moderator, Constance Benson.
Thank you so very much.